Hello, everyone. Welcome. I'm glad to be virtually talking again at your Pakistan meeting. I hope people are well. For a change, I'd like to talk about an update on Raynaud's phenomena. And although your country is warmer than mine, of course, you all see Raynaud's as well. These are my disclosures. So our objectives will be to understand who should you work up for secondary causes of Raynaud's phenomena, and how should you do that workup? How do you treat your patient with secondary Raynaud's? What are their complications that you will have to identify and treat? You should develop a treatment algorithm if you don't have one already. And it's really important that you start looking at the nail beds in the for capillaries being dilated or dropped out or hemorrhaging. And that's important to rule in or suspect secondary Raynaud's. So Raynaud's is a few percent of the population. It is more common in colder countries. And almost everyone with systemic sclerosis has Raynaud's, and it's often more severe in that group of patients than in primary Raynaud's. When we think of it, it's either primary or secondary. So primary, we can also call idiopathic. So it's not associated with another disease. Secondary is associated with other diseases, especially in a rheumatology congress. We're thinking of connective tissue diseases, but it can be vasculopathy of other sorts, from vasculitis, occupational, like hand vibration injury, people that work on a jackhammer doing road work, things like that can also be considered secondary because there's a reason for the Raynaud's. If we think of idiopathic Raynaud's in A, you see the pallor, well demarcated. It's circumferential around the finger. You also see in the second and fourth fingers the redness, and you can see on B that the fingers now got cyanosis. That third finger down here is now becoming blue. You can see it on panel C in the feet, so the toes. It's more common in hands than feet. And in panel D, this is a patient with decades of Raynaud's, primary, but you can see a lack of wrinkling, mild, minimal, sclerodactyly distal to the PIPs. You can see that kind of change in other conditions, such as long-standing diabetics. Where the tissues have become a little bit shinier, a little bit tighter. But sclerodactyly, that is from primary Raynaud's, will never go really beyond the PIPs. So as soon as you're getting sclerodactyly more proximal, we're going to think of sclerodactyly from diseases such as scleroderma. So it's about 3% of the general population, primary Raynaud's, and in families, that's 3 or 4-fold times higher. And if someone has systemic sclerosis, then they can have primary Raynaud's in their family at a higher rate as well. So Raynaud's increases the chance of Raynaud's. People with a connective tissue disease, including scleroderma, also increase the chance of Raynaud's. And so really that's a good pearl to remember, that if you have a patient, say, with Sjogren's, they have a higher chance of family members having Raynaud's, even if it's primary. Some of the mimickers are really not good mimickers because Raynaud's should have pallor. And if a patient's never had blanching or pale fingers, don't consider it's Raynaud's. So complex regional pain, they might have puffy fingers, they might be cold, there might be a change in sweating, they might go blue, but they don't go white. Acrocyanosis would be distal cyanosis. Exaggerated cold response. Many people can have mottled hands or feet in the cold. Peripheral vascular disease usually won't have pallor, so they'll be cold. Sometimes it is ischemic, but it's not with pallor, but it's not usually looking like classic Raynaud's. Pulses will be reduced or absent, etc. Carpal tunnel can have numbness and tingling, but it's not obviously Raynaud's. Chilblains are perniosis, are cold changes, usually distally on toes and sometimes on fingertips. which may or may not be associated with Raynaud's. So a person could have Raynaud's and chilblains or just chilblains. Trench foot is really more like frostbite, where there's cold changes. Frostbite, though, you could have one finger that was really damaged from cold, and that finger might later get Raynaud's. But frostbite itself is not Raynaud's. And then you can see some of the other mimickers, but mostly it's the history that sounds different than that triphasic change of Raynaud's. So how do you rule in or rule out secondary Raynaud's? So you would want to do a history on Raynaud's. Is it mild, moderate, or severe? Is it complicated or not? So if it's quite severe and complicated with digital ulcers, you're going to think of a secondary cause. You're also going to ask about a review of systems for connective tissue diseases, and you can think of the diseases lupus, Sjogren's, scleroderma, etc. Or you can just go head to toes, any dry eyes, dry mouth, hair loss, rash in the sun, etc. Inflammatory arthritis, and go down your systems by anatomically. On physical examination, you want to look at the hands a lot. So are there dilated capillaries? Are there digital pits? Does the patient have puffy fingers? You either want to do nail fold capillaroscopy, but for most of you, that's not practical in clinic. So you can use an otoscope, ophthalmoscope, dermatoscope to just magnify a periungual area. If Raynaud's onsets in older ages, we think of a higher chance of secondary, and it's actually at both ends. Children less than the age of 12 who get new Raynaud's, it might be secondary, things like systemic lupus erythematosus, or over the age of 40, especially way older years. If you're 70 years old and you get Raynaud's, there's usually a reason for it. And then you want to know, should you investigate patients if you get any hint of secondary? So if there's no hint of any secondary Raynaud's, I would not investigate them. So usually then no blood work is necessary, because you know that if someone has primary Raynaud's and you do an ANA, there's a high chance of it being positive falsely, because positive ANAs are so common. They're up to 3 women in the North America now have a positive ANA, and obviously only 1 in 1,000 has lupus or connective tissue disease. So you really do want to look at the nail beds, but you don't want to do an anti-nuclear antibody or the complete blood count or kidney function, chemical urinalysis, inflammatory markers. You don't want to do any of that without a suspicion. So if you have a suspicion, you'll do minimal blood work or more. If there's no suspicion of secondary, don't do the labs. So these, you can see dilated capillaries. So at the blue arrow, you're looking at just a vascular change on the cuticle. And if you follow it back, you can see some capillary change, and you can see it more on the other finger I'm showing you. And you can see a little bit of shininess. And when you look at this patient, you'd say, oh, lots of capillary changes, especially on the longer finger that I'm showing you. So you'd say, wow, that looks like secondary Raynaud's. And indeed it was. But if I show you the rest of the picture, this patient has rheumatoid nodules. So this was a man with decades of rheumatoid arthritis who then developed new Raynaud's after about 30 years of rheumatoid arthritis. So this is a nice algorithm, and if you want, you can certainly take a picture of any of my talk, but including this. So it really helps you to understand. So if age of onset is, say, less than 15 years or greater than 40 years, you might consider other a workup. You might consider what it might be, connective tissue disease, and there are the labs you might consider. Vasculitis, again, having other hints. Maybe you're seeing a vasculitic ulcer on someone's leg. Cryoglobulinemia, if you're seeing that they're always having distally blue feet and neuropathy. Vascular imaging, if you think it's, say, thromboangiitis obliterans from a smoker, formerly known as Berger's disease, etc. So you want to also say, are there any red flags on the history? So symptoms of connective tissue disease, occupational injury, but then you don't do the blood test workup, you say it's secondary to their occupation. Physical exam, especially the nail fold capillaries, but puffy fingers, etc. So this is just an algorithm you might think about of who would you work up. I received this slide a long time ago from Chris Denton, and it's showing the vasculopathy and systemic sclerosis, where you can see proximally on the fingers the digital arteries on both sides of each finger are mostly gone. And this is a vasculopathy that's also similar to what's happening in the pulmonary arteries, where you're getting proliferation for pulmonary arterial hypertension and scleroderma patients. You're getting proliferation of the media, but you're also getting endothelial changes and intimal changes. So it's very similar, but you don't have to have pulmonary hypertension in scleroderma, but about 15% of the patients have that, but almost all have Raynaud's. So here's some signs of secondary from my clinic that I've taken pictures of patients recently. So in A, you see the dilated capillaries and some hemorrhage. And again, if you see them on the cuticle of the one finger, if you follow backwards, you'll see it occurring in the periungual area. B is a patient with puffy fingers. You can see Raynaud's of that second finger, and she has systemic sclerosis. And C, that's a patient with early systemic sclerosis and puffy fingers. Puffy fingers can stay puffy, though, indefinitely in scleroderma patients with limited cutaneous systemic sclerosis, or they can go tighter over time. And you can see the telangiectasia on the patient D, especially on the lips. Here you can see complicated Raynaud's. So in A, you can see the Raynaud's different colors, but you can see on the palm telangiectasia. You can see there's tapering of that third finger with the Raynaud's in A from old digital ulcers. On B, this is a patient with dermatomyositis goitrans. You can see dry mouth from Sjogren's. You can see hair loss, alopecia from lupus. This patient with very terrible changes here on her toe and blue, and she's lost her nail and an ulcer. So secondary Raynaud's. This patient could have had systemic sclerosis, vasculitis, what have you. In F, you can see a patient with calcinosis that's been opening up from a patient with dermatomyositis. And in G here, this is a patient with systemic lupus erythematosus, but it's hard to tell. It's mostly sparing the PIPs, the rash, but if a rash is bad enough with either dermatomyositis goitrans or systemic lupus, a rash on the hands and fingers, sometimes it's hard to differentiate because it will stop sparing the knuckles or it will start involving the knuckles if it's lupus. So just showing you some of the secondary causes. In H, this is a patient that I'm seeing for severe, but she had primary Raynaud's, and a year later she came back with severe livedo reticularis. There was no use of a heating pad, just livedo has come. So she's obviously evolving into secondary Raynaud's of some sort. And this patient I here has leukocytoclastic vasculitis with her Sjogren syndrome. So if a person has Raynaud's and it's Raynaud's, what is the chance of getting a connective tissue disease? So it'll be increased if the patient has other signs or symptoms. If there's a positive ANA, especially a centromere pattern. If nail fold capillaries are abnormal. So if someone has either a positive ANA centromere pattern or abnormal nail fold capillaries, 1 in 3 will have connective tissue disease within 5 years. And especially if it's centromere positive, and within 5 years, 1 in 3 will have limited cutaneous systemic sclerosis over the next 5 years. So that's why we need to kind of look at who do we investigate and who don't we. And Raynaud's is common in our diseases. Primary Raynaud's, about 2 to 6% of the population, depending on the studies you read. And Raynaud's is about 1 in 5 patients with rheumatoid arthritis, but we don't always ask. In systemic lupus, it's about 1 in 4 patients. Sjogren's, 1 in 3 patients. Systemic sclerosis, almost everyone will have Raynaud's. And inflammatory myositis, at least 1 in 3 will have Raynaud's, especially polymyositis. So how do we treat Raynaud's? So most people don't need pharmacologic treatment. That's different when we talk about systemic sclerosis, but even in systemic lupus erythematosus and other connective tissue diseases, most won't need prescription medications. So cold avoidance, stopping smoking, so common sense, avoid psychological stress, avoid the cold. Calcium channel blockers would be the main treatment if we need medications. There's topical nitrates, angiotensin 2 inhibitors such as losartan can be helpful. Fluoxetine as one study. PDE5 inhibitors we use a lot in systemic sclerosis, prostacyclins such as iloprost, which is PGE1. Alpha blockers, although they can certainly give hypotension, but say if someone has BPH, a benign prostatic hypertrophy, and needs an alpha blocker for that and happens to have Raynaud's, it might help their Raynaud's, but that's not too many people that we're treating one drug to help both problems. And ACE inhibitors really don't work in Raynaud's. ARBs do, but ACEs don't. Okay, so what can I expect from Raynaud's treatment? Not a lot. For calcium channel blockers, you can reduce the frequency of attacks by about 30% reduction. So if someone has 10 attacks a week, maybe they'll have 6 attacks or 7 attacks a week. Often the severity of each attack and the time or duration of each attack are unchanged, and side effects are common: hypotension, flushing, headaches, a little bit of peripheral edema, especially if you're using a drug like amlodipine. A lot of people will have a little bit of edema in their around their ankles. And a clinical pearl is, if you increase the dose of the calcium channel blocker, you might get more benefit. So nifedipine, long-acting 30 milligrams, if you double to 60 milligrams, if it's tolerated and there's still a lot of Raynaud's, you might get more benefit, or even 90 milligrams. But side effects can increase as we go up on the dose. So this is just showing from our recent systematic review that we published in November. If you look at PDE5 inhibitors, so sildenafil, tadalafil, drugs like that, this is what you might find: a reduction in the frequency of attacks, again, from 1 attack a week less up to 5 attacks a week less on average. The duration of attacks might go down by at most 10 minutes. The severity of attacks might not change. It wasn't statistically significant, but if 10 is the worst, 0 is no severity. It might go down 3 points, but that's at best not statistically significant. It might not change at all. Pain might go down on a pain scale of 0 to 10. So if it doesn't even go down 1 point, it's really not relevant and it's not statistically significant. And patient global, though, can reduce, which is interesting, that's usually related to pain. The patient global can go down anywhere from 4.5 points on a scale of 0 to 10 to maybe just 2.5 points. So although it can be effective, it is modest benefit, and we use it when calcium channel blockers fail and bad Raynaud's, such as systemic sclerosis. So these are some of the drug targets that you would think about that might help Raynaud's, and this is not too different from somehow when we look at treatment for pulmonary arterial hypertension, but it's not identical. So those are some of the things you might think about. So in a recent review, we looked at management of Raynaud's phenomena, and we've also polled experts in systemic sclerosis. So this is looking in scleroderma, and now looking for both Raynaud's, and then on the next group for digital ulcers. So calcium channel blockers, the pyridine kind. So that is looking at nifedipine, amlodipine, felodipine, drugs like that. If not, PDE5 inhibitors, adding or switching depending on tolerability and benefit. And if not, iloprost would be third line. There's other ancillary treatments that might be used. Green has more randomized controlled trial data. A yellow, just maybe one randomized controlled trial or mixed results, and red, anecdotally being used, but no trials, just case series. And you can see in digital ulcers, it's kind of the same idea, other than bosentan and endothelin receptor can decrease new digital ulcers by about 30%. but it does not heal ulcers. Healing for digital ulcers would be calcium channel blockers, intravenous prostanoids like iloprost or epoprostenol, and then looking at some of the other drugs. Preventing ulcers, we'll talk about shortly, but bosentan would be one treatment. So there are unproven treatments, but certainly a digital or more radical sympathectomy surgical has no randomized trials, but certainly can help patients who have severe, like say, gangrene of a couple fingers. A sympathetic block can be helpful. So that's a stellate ganglion block for your hands up in your neck, or a lumbar sympathetic block if your feet are bad. Botox injections has lots of negative studies and some positive data. We don't have really where to use it, how much to use, but they go to the digital arteries of the digits that they want to block. Glucocorticoids do not help. Anticoagulation does not help Raynaud's, but if there's severe recurrent ulcers, I would think of antiplatelet drugs just to get better blood flow, like aspirin. But warfarin, unless if it's APS or things that isn't used. And biofeedback actually has some positive data, only in very few patients who can learn to control their temperature of their fingers by biofeedback and improve it. If we did a systematic review many years ago of complementary and alternative medicine, I think now there's 22 randomized controlled trials, and almost all of them are negative. Obviously, therapeutic gloves of any sort can be helpful. So in other words, wearing gloves that compress your fingers might help. Wearing mittens, it keeps your fingers even warmer. But most of the complementary medicine doesn't work. Lots of small trials where placebo is as good as active treatment. So what does EULAR recommend for Raynaud's? The dihydropyridine, sorry, I said it wrong earlier, dihydropyridine calcium channel blockers. That's nifedipine, drugs like that. If not, intravenous iloprost or other prostanoids, and also considering the PDE5 inhibitors such as sildenafil or tadalafil. And that's sort of graded to worse Raynaud's. Iloprost or PDE5s would be when they're failing calcium channel blockers. Here is one of our older treatment algorithms. Mild or more severe Raynaud's, interestingly, they went through the same algorithm, calcium channel blockers, and they would add or switch a PDE5 inhibitor to a PDE5 inhibitor, depending on tolerability and benefit. Then maybe they would go, if it was more severe, to prostanoids like intravenous iloprost. So they said if people are mild and going down the algorithm, they're probably actually getting severe. Complications, severe ischemia, could be acute or subacute, even chronic. Digital ulcers, osteomyelitis or deep infection, ulcer infections, auto or surgical amputation, digital pits or tuft resorption, where you're losing some of the pulp of the fingers, and tuft resorption. So in A, you can see the ulcer, and in the other finger that you see, well, she's lost some of the pulp, so that finger is getting shorter. In B, looking across the top, you can see the pit. In C, you can see amputations from a patient who had severe ischemia from a systemic lupus, systemic sclerosis overlap. On D, you can see gangrene. And if you see it in one finger, we're worried about other fingers. So you can see the second finger is turning dark as well. And in B at the bottom, you can see some of the desquamation, and the patient has developed pits as well, that you can see the one that I've marked on the upper hand, quite easily seen. So here, this is a patient I'm currently following. You can see the severe tuft resorption. She's losing fingertips. There's no padding, and she's losing the bone of the fingers on the x-ray, acroosteolysis. You can see almost all the distal phalanges have disappeared. And this patient is having recurrent ulcers. She's lost lots of her fingertips and continues to have nail lifting, severe pain, and ulcers as she is getting her acroosteolysis. We have to worry about as well as things become possibly infected, to treat infection. So for severe ischemia or threatened gangrene, it's serious. You want to maximize the calcium channel blockers, such as high-dose nifedipine, if tolerated. You want to add or switch to iloprost or use a PDE5 inhibitor. If you can't get iloprost, you might think of Flolan, epoprostenol. L-prostadil, PGE1, doesn't work as well, but could work to get someone out of the crisis. Consider stellate ganglion blocks. You want to control the pain. You want to lubricate those ulcers, not just always dry them out, but you need to treat infection. You might give a barrier like topical antibacterial cream just to give a barrier for a patient. You might want to sometimes cover it if they're out in public. And infection, you need to treat whether it's oral or intravenous antibiotics if infection is present. And sometimes it's tough to tell. So the other clue or hint about digital ulcers in our systemic sclerosis patients is they're often multiple. So you can see the ulcer in the top hand there, a little ulcer that's healing. You can see in the second finger of that top picture that she's already lost some tuft from a past ulcer. She lost some tuft or pulp as well at her thumb. On the lower one, you can see 2 ulcers active at a time here. So often they're multiple active in patients. Another clinical pearl is if someone with systemic sclerosis or anyone with Raynaud's who is getting more feet, toe ulcers than hand ulcer, finger ulcers. Think of peripheral vascular disease superimposed, microvascular or macrovascular. Macrovascular we can treat. We can possibly get an angioplasty. So look and feel for the pulses. And if it's microvascular, you can at least treat traditional problems such as high cholesterol, type 2 diabetes, etc. But if it's more in the feet than on the hands, there's vascular disease superimposed, in my opinion, micro or macrovascular. So this is what I do for digital ulcers. So the data mostly are not very good data on our early lines of therapy. So for healing, anything that will vasodilate in Raynaud's might be helpful. Calcium channel blockers, prostaglandins like iloprost, or sildenafil or tadalafil. For prevention, so the healing also could help for prevention, but for prevention, drugs like Bosentan, which in Pakistan you have generics that are far less expensive than in North America, but Bosentan does not heal ulcers. It reduces new ulcers by about 30%. Moderate dose atorvastatin, 40 milligrams a day, in one randomized control trial also decreased new ulcers by about 30%. So statins are also inexpensive and you might want to consider them, but they're not part of any guidelines, just one trial saying in scleroderma they prevented new digital ulcers. What does EULAR recommend for digital ulcers? They say calcium channel blockers. After that, either intravenous prostanoids such as iloprost, and then Bosentan to prevent new ulcers. The other endothelin receptor drugs didn't work, and the other prostacyclins, such as treprostinil, didn't seem to work in one trial, but it was probably worked early, but the healing of ulcers over time was no different. These are some of the systematic review we did years ago showing that you can try to prevent ulcers with nifedipine if you look on the lower part, but it's only studies within Raynaud's trials of systemic sclerosis patients. You can see how small the N was with those with ulcers. So not very good data, but certainly favoring treating ulcers as opposed to not helping ulcers. Sildenafil again, Bosentan will reduce ulcers but not heal ulcers. So the prevalence of ulcers and scleroderma is at least half the patients. So in this study, it was 58%, but about half our patients have digital ulcers ever with scleroderma. If they have one on any day, they often have multiple. So the mean or median number of ulcers, if they come in with them, is 2. but you can have from 0, of course, to many, or from 1 if they have ulcers to many. And 15% of patients on any day with scleroderma will have a hand ulcer. Not always fingertip, it could be ulcers from flexion contractures at their PIPs, but they're very common in scleroderma. So for our 15% rule, everybody with scleroderma almost has Raynaud's. 80% have GERD and or dysphagia. Half have digital ulcers ever, 58% in that other study. This is our systematic review where it was about half. And any day, 15% have a current finger ulcer, of which 15% ever are complicated. Complicated meaning the ulcer has gangrene, osteomyelitis, needs to be amputated, etc. 8 to 15% of your patients have pulmonary arterial hypertension. In early diffuse, 10 to 15% will have scleroderma renal crisis, but just 3% overall of your patients will get renal crisis. 1 in 3 will have interstitial lung disease, or mild or moderate or severe pulmonary fibrosis, but in half those patients, it's clinically relevant, 15%. 15% will have inflammatory arthritis, 15% will either have a myopathy or myositis, and 15% will have Sicca or Frank-Sjogren syndrome. So it's just a good little 15% rule way of thinking about what's important for our patients to screen for, and especially the bolded ones that I'm showing because we're talking about digital ulcers and Raynaud's. I've adapted this slide from Chris Denton as well. So you want to use your digital ulcer algorithm in helping your patients. So improve blood flow, so vasodilators, give analgesics because often these ulcers are quite severe in pain. Consider an antiplatelet drug such as aspirin. Use antibiotics only if there's infection. Parental prostacyclins like iloprost, advanced vascular therapies such as bosentan to prevent new ulcers, or sildenafil to treat or prevent ulcers, statins, high dose atorvastatin 40 milligrams or medium dose to prevent new ulcers. Debriding an ulcer if it's infected or if it's covering over but deep inside hasn't started healing. So you often have a multi-targeted approach and an approach with other people helping you, such as possibly plastic surgeon, vascular surgeon, orthopedics if we need an amputation. Some wound care nurses can be very helpful to our patients. So in conclusion, Raynaud's is very common. Idiopathic or primary Raynaud's, about 3% of the population. It's usually mild. Even in secondary Raynaud's, it's usually mild, such as Sjogren's or lupus. And vasculitis or severe lupus, you might have vasculopathy, gangrene, etc., that needs treatment. Raynaud's and scleroderma often needs treatment. Pain control is important if people have digital ulcers. Digital ulcers occur in about half our scleroderma patients, both limited and diffuse, often in longer standing disease where vasculopathy is getting worse. Then it's often worse. They can be cyclical. You can have 3 ulcers this rainy, damp season and none for, the next 2 years. So they can be quite cyclical. We want to heal digital ulcers by increasing blood flow. We want to prevent new ulcers by either drugs that increase blood flow or possibly bosentan. If there's an amputation of a fingertip ulcer, chances are you're going to have another amputation, at least a 1% chance every 6 to 12 months of further amputations, because the vasculopathy is quite widespread, of course, in our patients, really involving in general all digital arteries of hands and feet. So I can't do my work without funders and really without thanking the patients as well. So with that, I thank you for your attention.